Let's talk about
Yep.
scaling via the bunkered model. The practice has literally, I mean, it's seen remarkable growth, expanding from 7 providers in 2019 to over 90 in 2024. Can you explain the logistics of your bunkered model and how the global virtual waiting room allows a single clinician to effectively manage patient volume across multiple states like Florida, Texas, and New York?
Absolutely. So this is definitely a loaded question that you could probably do an entire hour-long in-service just talking about. So I'll do my best to keep it short and sweet and touch on all these points here. So again, naturally, I'm going to just, blame COVID for sort of the acceleration of going from 7 to 90, because I want to say we probably went from probably like 20 to 70 during 2020 to 2021. It was very fast. I would say that was the sort of the catalyst to the explosive growth. Again, just because based on needs, that's what popped up. We were mainly a Florida practice at that time. We had just acquired our Texas organization that we were starting to work with at that point. So we were really focused on Florida mainly during the pandemic. So that really made things simple in hindsight of what we're doing today, how simple and easy things were then. We were dealing with one state, one group of payers, one set of licenses, one time zone. Really all the things that we sort of deal with now that have turned into challenges with credentialing, with enrollment, with just, again, individual states having different rules and regulations around how telehealth can be administered, when it can be administered, supervisory setups in order to meet local and state regulations. It's become complicated. And we've sort of discovered some of those complications as we've moved from east to west now, obviously hitting Texas, and we bundled New York and obviously to our East Coast practice. But we're now really running into some of those big challenges in California and a little bit in New York as we're trying to scale that practice because regulation is very heavy in those two states around telemedicine. So again, probably could do a whole hour session on that, but won't bore everybody with the granular details. But the virtual waiting room for us has been, obviously, I mentioned this before, but I'll give a little more detail. We are mainly on-demand practice. So about 80% of our visits are on demand, about 20% are scheduled, which is definitely unusual. As we've talked with you guys, talked with EMR vendors that we've made some EMR changes over the last few years. Some of them have telemedicine baked in, some don't. None of them have anything to serve on demand. It's just not, it doesn't exist. So it's definitely something we do that's very niche for us. And I have mixed emotions on whether it's the right thing to do long term to scale with a pure on demand model, just because it does make it very difficult to staff and to manage wait times and to be responsible with our salaries. But the technology that we have partnered with you on to create has made it possible for us to operate in an on-demand world. So the global waiting room basically allows us to have an API that goes across to our EMR vendor and move patients in between clinicians, which is nice. So we have sort of a database of clinicians through our EMR that are divided into East, West, and Central. So we have 3 EMR instances. And the integration between eVisit and Pediatric Associates allows us to sort of send the patients to the right place once they hit our global waiting room. So the global waiting room is kind of like a proxy user that we use. It's not an actual clinician. It drops in there. And then we have our coordinators basically look at the patient, look at the instance they dropped into, and then assign them to a clinician that has an available slot. So we have templates that our clinicians use that are regulated by a certain amount of visits per hour. And then the clinicians are then able to obviously follow their kind of just standard template like any clinician would in an office. And obviously we use that to sort of measure where we're at with wait times, where we're at with patient access. We look at fill rates, we look at all that type of stuff. So we know when it's time to add patients. Add clinicians. We always want to add patients, but we need to add clinicians so we can continuously add patients. So we've spent most of our time really over the last 2 years where we haven't been growing quite as aggressively because absent a pandemic, which is a good thing at the end of the day. We are obviously now looking at ways to, as we talked about earlier, use newer technology, AI, machine learning, to help us make decisions of where patients should be distributed to without needing human intervention. Human intervention is obviously a bottleneck point. We have coordinators that, they're normal humans. They call out, they're sick, they have technological issues, they have, we have surges in volume. We have some hours, we have 120, 130 patients arrive to our waiting room, and we have the next hour 50. So it would be nice if we had, a little bit more technology there. But again, that's what's been nice about this partnership with EVIS is we're able to talk about that stuff, and there seems to be a pathway to unlocking those type of things where, like I said, with our previous vendor, we were sort of hitting the developer wall where there were no APIs available. There was not a team that was really interested in developing it beyond just a big box product. And again, that's where eVisit and us have come together, and we've made some improvements to make it possible to use a global waiting room model and then distribute patients within their own markets without obviously bloating wait times or creating friction points for the patient where they would become a customer service complainant.